Greetings from CSI Delhi branch, eMedicine News and Heart Care Foundation of India. Welcome to our show, Chat with Dr. KK. We have with us Dr. Sandeep Mishra, who is Additional Professor of Cardiology at All India Institute of Medical Sciences. He is also the Chairman of National Interventional Council. Welcome to our show.
Thank you, sir.
When we talk about interventional cardiology, there are expanding indications. Now we can do replacement of the valve, aortic valve, without doing the surgery. We can repair the mitral valve without doing the surgery. We can treat hypertension, resistant hypertension. We can take care of refractory heart failures by doing renal denervation therapies. A, is our country prepared for them? B, are the facilities available? C, are we competent?
Okay, so actually very good question. Number one, first of all, do we have the patients? So I think all of us know that we have lot of patients, especially rheumatic heart disease, aortic stenosis, even mitral regurgitation patients. The only problem is that those patients have not been studied in whatever studies are available from Western literature, because what they have studied is degenerative AS, what they have studied is coronary artery disease, mitral regurgitation, end stage kind of failure where they lead to mitral regurgitation. So we need to study these subsets of patients in Indian subjects, whether the same devices or modification of these devices would be applicable to our context. So that is number one. We have lot of patients, but whether we can adapt this particular therapy for our patients, that is the question that we need to ask. Second question is, are we capable? I think at the moment, we are one of the people who are very much capable of doing these things, because we are already doing aortic valve balloon dilatation, we are already doing, mitral stenosis dilatation. So we are into structural heart disease and we are doing lot of work already on structural heart disease. So for us, it is pretty easy to do these procedures.
When it is easy, then why Government of India had put down so much restrictions that they say not allowed, permissions, individual case, something like we're doing a renal transplant that you require individual permissions? Why?
So number one is that, while as I said that although we have lot of experience in mitral stenosis dilating, aortic stenosis dilating, but this is the next generation. So while it is easy for us from coronary to shift to this arena compared to West, but still it requires a lot of training still, because it is not like a regular mitral stenosis valve dilatation, it's much more than that. So we require a lot of training, but I think the main reason is that the therapy itself is very, very expensive. So for example, if you take aortic valve replacement percutaneous TAVR, then it would cost something in range of 18 lakhs to 20 lakhs. So the therapy is very expensive, and I think people are worried that if it gets into the mainstream, then it will open up Pandora's box, because insurance will come in and then people will want themselves to get insured for this particular therapy, and then you can imagine with lot of patients here with this kind of cost. Mitra clip is actually 25 lakhs. So this kind of therapy coming in, and it will open up the whole Pandora's box.
So, but as on today, if you want, you can go to you can take special permissions and import.
You can, for individual patients who are so well affording, they can get it done. Expertise also at the moment is not available in country in a great way, but people get international experts to help them around, and already, as I said, people are well versed with structural heart disease interventions. So it takes just little more for them to learn.
So how many cases have been done in India so far as far as TAVI is concerned?
I think that number should be in single digits.
Not 10
at the moment.
Not yet.
I think it must be somewhere around 10.
What about clips?
Clips, no, not done.
Not done at all.
Not done.
Now the third one comes is renal denervation, which now people are very much excited that probably every hospital will start doing it.
Yeah.
What are the cases where renal denervation?
So basically, if you look at the taking up indications, you will find that they are end stage hypertensives who are uncontrolled on 3 medication, including diuretics
and sympathetic overactivity.
So you can find those patients. The problem is that this therapy may get overused, so that people, even if they are not meeting the criteria, they might be taken up, and they might be afforded. And unlike angioplasty, where you can have clear cut outcomes, you can see on angiography. So if you have a tight narrowing 90%, you open it up and then you put a stent, you can see that narrowing has gone away, and you can even look at the stent. Here, renal denervation, nobody knows what happens. You just put in a catheter, inflate the balloon, come out. Whether you did it or not did it also,
Same thing like an ablation in a...
Right. But ablation, you have ECG changes. You can see if you are doing a fast pathway
So
ablation.
here there is no criteria to say whether the renal denervation was done or not.
Exactly. So the simple thing would be, if I'm just thinking, being the devil's advocate, if somebody wants to do a renal denervation, for example, he can just take a patient, just tinker a little bit with medication, he will become resistant. Just do this procedure and just again tinker with the medication, and he will get control on it.
So the loopholes are there, and they will be.
So I think that is the worry. I think that is the part. It could be misused if it is not properly handled. So we need to have mechanism to make sure that everything goes right.
What about heart failure?
Heart failure also, this is like, I'm talking of end stage heart failure where there
Hypertensive
are
heart failure. Or
end stage heart failure, any end stage heart failure, we know there is a sympathetic overactivity, and we use drugs, for example beta blockers, to control the sympathetic activity. Now this denervation is one way where you can also control sympathetic denervation, you can do.
Okay, in intervention, any other apart from TAVI, clips and
I think in intervention, let me just move little bit in the interventional arena itself. There are now we are having leadless pacemakers. So you just like a balloon, you put something there and remotely you control the heart rate. So you don't have to
Explain it again. How do you put it?
So there is a device, you take it inside the heart, and
it will be very small device.
Very small device, and you inject it in the heart, and you implant it in the muscle. And then you have a remote device somewhere which will just activate and start giving the impulse. So that means you don't need to make a pocket, don't need to put a pacemaker here, don't need to put a lead into the heart. You can just put like a percutaneous device which sits there. It's a remote sensing device, and through remote sensing you activate it and it starts giving the impulse.
Is it available?
No, not available. What I'm saying is these things are coming.
Yeah. That's the future.
And same thing with ICD. Instead of putting the whole ICD, you just put this device. So this device remotely senses the rhythm and it can give a shock, and also remotely senses the rhythm, and it can give
in another 3-4 years it will be there?
Maybe little longer, but 3-4 years it will definitely come in the picture. It will be in the
any other advancement like this?
I think, sir, a lot of advancements are there. Now people are thinking of using certain drugs which will go and sit there and will not let MI develop. Detection of vulnerable plaques. So that is one. So what they will do is they will image the whole heart, find out which parts are vulnerable, which are likely to get into myocardial infarction, identify those parts and cover them with stents, so that later on they don't develop myocardial infarction and
So we are talking about non-invasive or invasive detection of vulnerable plaque.
Invasive detection.
Invasive detection
at the
of
moment.
vulnerable plaque.
Maybe later on non-invasive also.
Once you're talking about vulnerable plaque, suppose I do the carotid. What are the methodologies available non-invasively, indirectly? I'm talking about surrogate markers that this is a vulnerable plaque.
In carotids, one is intima media thickness and those echocardiographic, those ultrasound parameters. There are some parameters which can suggest. But there are a host of new modalities now coming up which can look at this. There is a CT which can look into vulnerable plaque situation. There is MRI which can look into vulnerable plaque situation, and so these are remote imaging mechanisms. And then there are invasive mechanisms like palpography, thermography, where you can actually difference in the temperature tells you that this part may be vulnerable. So it's a whole area actually which is coming up.
Anything in prevention? Anything latest?
Prevention, there are now people are thinking of some particular drug being given which can cause regression of atherosclerosis and complete dissolution of plaques.
Which drugs we are talking about?
I think there are some numbers now.
Numbers now. And what about this, the ACC about niacin, that niacin is no more effective and it may cause harm?
So yeah, of course, that concern is there. Basically what was supposed with niacin was that it was improving the HDL. Now, since that time we have moved forward, we have realized that there are different kinds of HDLs. There is good HDL also, and there is not so, neutral HDL also. So now the whole focus has shifted to whether we are able to increase the good HDL or not, which does not seem to be happening too much with niacin. It is increasing a little bit. So that is why, maybe the effect is little equivocal. And we may still wait for some studies, but more or less the verdict is out that maybe niacin is not working that much. It's not affecting,
So what Dr. Sandeep Mishra says is, a time is going to come, you may have a pacemaker without a wire. You will have a aortic valve surgery occurring in rheumatic aortic valve disease, where you may be able to put in a catheter using a valve using a catheter, You may be able to repair rheumatic mitral valve lesions with a clip. You may be able to treat resistant hypertension and resistant heart failure with renal denervation. But he always gives you a caution. In India, beware. We need guidelines, we need some control, we need some regulatory mechanism so that they are not overused. Well, thank you to be here with us.
Thanks, sir.
That's all for today. We'll come back with one more show. Till that, goodbye. Thank you.
Thank you.